Hemolytic anemia. What is hemolysis? First of all, let me say hemolysis is not hemorrhage. Although both of them, you're losing red blood cells. But in hemorrhage, you're losing red blood cells to the outside of your body. You bleed, you lose the red blood cells out. But in hemolysis, you lose the red blood cells, but you're not bleeding. Something happens inside your body, and the red blood cells just die prematurely. They kind of rupture prematurely. This is hemolysis. So, why? Why does hemolysis happen? Maybe you are born with a congenital problem inside your red blood cells, like congenital spherocytosis, thalassemia, sickle cell anemia, G6PD deficiency. You have a problem, congenital problem. Or you're born with normal red blood cells, but you acquired a problem outside, like autoimmune hemolytic anemia, uremia, malaria, metal cardiac valves. All these are extracorpuscular acquired causes of hemolysis. And the second question you need to ask yourself, where? The most common site of hemolysis is in the spleen. But sometimes you can have the hemolysis taking place inside your blood vessels, where we call it intravascular hemolysis. Any hemolysis will result in, regardless where does it occur, extravascular in the spleen or intravascular in the blood vessels, will result in characteristics, 4 characteristics. High retics, elevated reticulocytes, high bilirubin, the indirect bilirubin, high LDH, and low haptoglobin. If you want to remember just 2, remember high retics and high bilirubin. Hemolysis, high retics and high bilirubin. Regardless, is it occurring in the spleen? Is it occurring in the blood vessel, intravascular, extravascular? High retics, high bilirubin. But whenever you have intravascular hemolysis, in addition to the high retics, high bilirubin, you're going to get free hemoglobin in the blood, hemoglobinemia. You're going to get hemoglobin in urine, hemoglobinuria. You're going to get hemosiderin in urine, hemosideриnuria. Both of them, whenever you have chronic hemolysis, your bone marrow is hyperactive and you're going to pass into folate deficiency, and this overproduction of bilirubin can result in gallbladder stones. Whenever you see a gallbladder stone in a young patient, 10-year-old, 12-year-old, think of hemolysis. And the intravascular hemolysis on the long run, you can get iron deficiency as well. Clinical manifestations of hemolytic anemias, you are going to get the manifestations of anemia and the manifestations of hemolysis. And they depend on the degree of hemolysis, the degree of hemolysis. So in addition to the tiredness, fatigue, and pallor, you can get jaundice, too much bilirubin. You can get gallstones. Although the bone marrow in hemolytic anemia is compensating by being hyperactive, sometimes it stops working all of a sudden following a parvovirus B19 infection. What does it cause? Parvovirus B19 causes upper respiratory tract infection. Can you believe that? 1 week following upper respiratory tract infection in a kid with hemolytic anemia, the kid's hemoglobin falls to 3 grams, 2 grams, very, very low. Why? Because his bone marrow stopped functioning. Why? Parvovirus B19. Splenomegaly. All hemolytic anemias are characterized by big spleens. Why? Because this is where they destroy the red blood cells. Thromboembolism. Parts of these destroyed red blood cells can result in embolic manifestations. And the treatment of hemolytic anemias in general, try to deal with the cause, especially if the cause were in the acquired types. Try to remove the cause and manage the crises. And we can give monoclonal antibody therapy as well. Let's talk about sickle cell disease. Sickle cell disease is inherited as autosomal recessive disorder, And in this genetic mutation, the valine replaces glutamic acid, and this leads to the formation of the abnormal hemoglobin S. Hemoglobin S is going to react to any deoxygenation and any dehydration by solidifying and stretching the red blood cell into an elongated sickle shape, leading to 2 major consequences: hemolysis and anemia, and vascular occlusions leading to pain and organ infarction. Very characteristic in sickle cell. You get organ infarction, and that's why sickle cell patients, when they live long enough to become adults, are the only patients with hemolytic anemia who have small spleen. Originally, their spleen gets bigger, splenomegaly, as any hemolytic anemia. But as they grow and they have a lot of these vascular occlusion crises, a lot of organ infarctions, they develop mini infarcts in their spleen, and they develop autosplenectomy. They remove their spleen by themselves by these repeated infarctions. Therefore, patients with sickle cell disease, they have smaller spleens or even absent spleens when they are adult. We have sickle cell trait when you have just one hemoglobin S gene, but the sickle cell disease resulting in the anemia when you have two genes having this mutation. Clinical manifestations, again, the extent and severity of sickling will depend on the percentage of hemoglobin S, how much hemoglobin S do you have inside your blood, and it's usually a chronic disease with acute exacerbations. What can trigger sickling? Cold, stress, physical exertion, infection, hypoxia, dehydration, acidosis. All these can trigger sickling. Extensive sickling can precipitate 4 types of crises: vaso-occlusive thrombotic crisis causing infarctions, aplastic crisis causing acute anemia, and this follows what? Parvovirus B19. Sequestration crisis. Patients, when they are young and have big spleens, this big spleen can sequester big volumes of red blood cells, leading to cardiovascular collapse, and of course hyperhemolytic crisis leading to jaundice. Acute chest syndrome is atypical pneumonia resulting from pulmonary infarction, characteristic also of sickle cell disease. How to treat sickle cell disease? Very important, prevention of infections. Please be very aggressive, be very generous with antibiotics in these patients. And you have to do something for pain management when they develop these vaso-occlusive crises. Use transfusions very very wisely, because you don't want these kids to develop complications of blood transfusion. Hydroxyurea is also a useful drug in managing sickle cell disease. Our case study is about an 18-year-old African-American male with sickle cell anemia who presents with a one-day history of increasing pain localized to his arms and legs. The pain intensified approximately 36 hours after a workout at the gym that was more vigorous than usual. The past medical history. The patient was diagnosed with homozygous hemoglobin S disease at the age of 11 months. He first presented with a severe case of dactylitis at about 10 months with significant pain and swelling in both hands and feet. And this is what is dactylitis: inflammation of the fingers and toes, swelling, pain in both hands and feet. At age of 16 months, the patient was hospitalized with acute sequestration syndrome and splenomegaly. The patient was also hospitalized twice later on for pneumococcal pneumonia. Now, what precipitating factors probably triggered this painful crisis? Likely precipitating factors include overly vigorous exercise, increased use of oxygen causing lower oxygen tension, and decreased blood volume from sweating and non-drinking enough fluids. Furthermore, there are significant clinical manifestations of dehydration in this patient. So dehydration is a common precipitating factor for sickling. What specifically is causing this patient's current pain crisis? Vaso-occlusive obstruction of capillaries in bone, resulting in hypoxia from this sickle cell blocking the blood vessels. Identify these patients' 2 major risk factors. The 2 major risk factors are ethnicity, African American ethnicity, and both parents tested positive for the sickle cell trait. Which single clinical finding provided a definitive diagnosis of sickle cell anemia in this patient? Of course, identification of hemoglobin S and the proportion of hemoglobin S. 82.5% of hemoglobin S, that's a lot. Can you list the clinical manifestations that are consistent with sickle cell anemia in this patient? Yes. Chronic low-grade pain in arms and legs and back. Episodes of dactylitis. Episode of acute sequestration syndrome with splenomegaly as an infant. 2 episodes of pneumonia as a young child. 1 episode of osteomyelitis. Admits to feeling tired much of the time. Prominent systolic ejection murmur, anemia. Limited range of motion in joints. Peripheral blood smear showed what? Sickled or crescent-shaped red blood cells. Echo showed dilatation of the right ventricle. Can you identify 3 clinical blood test results that were elevated and explain why? Total bilirubin, indirect bilirubin, proportion of reticulocytes in the blood. Why? Because these are the products. These are the products of the bilirubin is the product of hemoglobin metabolism, heme metabolism, and the reticulocytes increase as a compensation. Their bone marrows try to compensate for anemia by working more and producing more retics.